Tibial fracture, intramedullary nailing with TRIGEN meta-nail. Semi-extended approach, blocking screw guide, and the sure-shot distal targeting system. Case presentation.
Okay, so this is the 84-year-old patient with the mid-shaft fracture of the tibia, distal fibular fracture, proximal fibular fracture, and fracture lines which reach far into the proximal metaphysis. So what we feared is that if you treat that fracture with an intramedullary nail, conventional approach, you have to flex the knee 90 degrees, so you will risk the dislocation of the now nearly undislocated proximal fracture. Now, that's why we've chosen the semi-extended approach
And opening the medullary canal. The patient with the multi-stage tibial fracture is placed in the supine position on a radiolucent table. The patella and tibial tuberosity serve as landmarks. The skin incision is made above the superior pole of the patella and should be approximately 2 centimeters long. Following the skin incision, the subcutaneous fatty tissue is dissected. Blunt dissection continues with the scissors down to the quadriceps muscle. Two Langenbeck retractors are then inserted, and the medial extensor apparatus is exposed by the median skin incision. Next, the medial extensor apparatus is split with the scissors and the knee joint is entered. This step is designed to mobilize the patella. As soon as the approach to the knee has been created, the access instruments, consisting of the entry tube, entry portal handle, and guide pin sleeve, are assembled, clicked into place, and then advanced into the knee joint. The guide pin can be inserted into the tibia in the desired position via the guide pin sleeve. You can already see that both the AP and lateral planes are readily accessed by the C arm. But it is also important here to check the correct position of the guide pin. If the guide pin is not ideally placed, a second guide pin can be inserted via the honeycomb module. As soon as the guide pin is correctly positioned, the medullary canal can be opened. It is important to ensure that the entry portal tool and entry tube remain in the knee joint during this step. All subsequent steps are completed via this entry portal tool. The fracture is first threaded with the reducer. This reduction aid is also introduced into the medullary canal through the entry portal tool. Both fractures are now bridged until the distal section is correctly positioned centrally in both planes. You can see here how the comfortable positioning of the leg, with the patient in a supine position, significantly facilitates the manipulation and imaging of the fracture fragments. As with all tibial fractures, a correct distal position is important. And this can also be achieved in a controlled manner using the semi-extended approach. The guide rod is now introduced via the reducer and placed exactly in the distal fragment. The reducer is then removed from the medullary canal. During this step, the guide rod can be secured in position with the obturator, thus preventing any accidental withdrawal. The next step is length measurement. To this end, the ruler is advanced over the guide rod down to the bone insertion point through the entry portal tool. This allows for precise length measurement. In our case, we have selected a slightly shorter nail in order to allow for backslapping of the nail and compression of the fractures. Following the length measurement, the medullary canal is now drilled with limited reaming. The nail thickness is also determined at this point. In the metaphyseal area, the canal is not reamed wider than the nail in order to preserve the cancellous bone structure here for added stability. Here, too, you can see that the use of the obturator prevents any displacement of the guide rod. With this approach, too, the medullary canal is reamed in stages. Starting with the front-cutting 9mm drill and then increasing in 0.5mm increments. Mounting the drill guide and setting up the sure-shot distal targeting system. The selected nail of the appropriate thickness and length is now mounted on the extended drill guide. Take care to ensure that the nail is correctly connected to the drill guide with the aid of the marking. To test the sure-shot system, the set stop can now be mounted on the drill guide and the probe inserted to the correct length by pressing the button. As soon as the button is released, the probe clicks into place. The probe ends 2 centimeters above the proximal hole of the distal locking screws. The set stop is now secured to the extended drill guide. As soon as the probe is inserted into the nail, it can be connected to the monitor. You can see that the monitor recognizes the probe. The targeter is then connected to the monitor. The drill sleeve and nail length and thickness to be used are then selected. Insertion of the tibia nail. The nail is now inserted over the guide rod, which is already in the correct position. You can see here the longer drill guide and the smooth transition between nail and drill guide. The fracture is usually bridged under fluoroscopic control. Radiological imaging is still needed at this point to ensure that the nail is correctly positioned. Here too you can see that the whole setup and positioning significantly facilitates the checking process. As soon as the nail is in the correct position, the guide rod is removed. The probe with the set stop on the drill guide can then be inserted into the nail. Distal locking with sure shot. The system is now ready for distal locking without radiation exposure. To this end, the skin is first marked at the site of the stab incision for the screw. The drill sleeve is provided with small teeth, enabling the skin to be marked here and the correct incision point to be identified. This allows smaller incisions to be made. The targeter is then placed against the bone, and the green circle is centered over the locking hole. The red circle is then centered over the green circle. Drilling can begin as soon as everything is correctly aligned. No image intensifier is required, either for the targeting or the drilling. The length can be read on the drill, which means that the length of screw can be measured and determined as soon as the lateral cortex is reached. The screw is then inserted. The distal locking screw can then be inserted, once again without any need for manoeuvring the C-arm. First, the green circle is aligned over the locking hole, and then the red circle is aligned over the green circle. The length can also be measured here via the scale on the targeter and the drill. The situation can be checked on the monitor throughout the drilling process. For the AP locking screw, the targeter simply needs to be swiveled. The computer automatically recognizes the orientation in the AP plane. Here too, the skin incision can be determined using the targeter. If necessary, the view on the monitor can be adjusted using the touchscreen. Another advantage of this system is the protection afforded to the vessels and nerves by the drill sleeve. If there is any doubt about the screw hole alignment, the targeter can be used to insert the screw by guided navigation. This is advantageous, for example, for retrograde femoral nails with a relatively large soft tissue covering. Here, the computer recognizes the orientation and shows the position of the screw in relation to the locking holes. This procedure guarantees reliable insertion of the screws. You can see here that the screw is secured to the medium hex driver. Once distal locking is completed, the probe can now be removed and the anterior drop mounted for the proximal locking. Since a multi-stage fracture is involved in this case, Poller screws should be inserted to avoid secondary displacement. You can see that the screw is secured to the screwdriver and can be inserted using the drill. Checking under the image intensifier is not absolutely essential, but can naturally be carried out if so desired. Here again, you can see how the whole positioning setup is advantageous. You would otherwise need X-ray control in order to insert a Poller screw in the exact position. This is not necessary with the TRIGEN system. You can mount a blocking screw attachment on the anterior drop to facilitate exact positioning of the Poller screw. Here too, a stab incision is made and the hole drilled. And the screw can be inserted through this blocking screw attachment. If the Poller screw is needed for reduction, a different inlay can be used, and this ensures that the subsequent Poller screw is centered in relation to the nail. Proximal locking, refixation of the ligamentous apparatus, and wound closure. On completion of the proximal locking, the anterior drop and blocking screw attachment can now be removed. The drill guide for nail mounting can then be removed, and the knee joint liberally irrigated. Following irrigation, the medial ligamentous apparatus is exposed and, using two Langenbeck retractors, the skin is pulled into a tent shape so that the ligamentous apparatus can be refixed properly and securely. This is important for restoring ligamentous control of the patella. The ligament reconstruction with xerovicral sutures is followed by subcutaneous approximation of the soft tissues with interrupted 3 xerovicral sutures. After a check for correct patella tracking, the skin can be sutured. Postoperative checks.
And what you can see here is the postoperative result. You can see here the midshaft fracture of the tibia, which is well reduced. Anatomically, you can see the AP screw, which was brought in with the sure shot without X-ray. And here you can see the proximal fracture, which is not secondary dislocated. It's reduced, and what you can see here is the blocking screw, which was guided through the jig and the blocking screw guide. So we didn't have to figure out where it could be or should be. So we had good guidance. Okay, so this was lateral. In the AP view, you can see again the midshaft fracture, which was well reduced. You can see the non-dislocated distal fibular fracture and the proximal fibular fracture. And you can see here the 3 screw fixation distally, and here the blocking screw, which was brought in with the blocking screw guide to give more stabilization and reducing the risk of secondary dislocation.